I'm sorry for being a grouch last time I was sick. And I am a grouchy sick person. And my second announcement is that you guys were wrong about this question. And I mean that in the nicest way possible. You kept trying to tell me it was C, but it's not C. Because the afferent arteriole goes afferent arteriole and then glomerulus, yes? And then efferent arteriole and then peritubular capillaries, okay? So you tried to tell me it was that one, but it's actually that one. Okay, so I did go back and look at it, but I was still right, even though I was sick and grumpy. Go ahead.
Sorry, one question I was confused on is the fetus to placenta.
Uh-huh.
Can you explain that? It's an artery if it goes from the fetus.
So when you are talking about the umbilical artery and vein, it's with reference to the fetus, not with reference to the mom, okay? So what the hell? What did I just do? Hold on. I accidentally did something. Force quit. I don't know what you're doing. Okay, so the umbilical artery, yes, is an artery with reference to the fetus, which means it's going to go, no. What is an artery?
It goes to the heart.
No.
It goes away.
Oh,
Away from the heart, yes. So the umbilical artery in the fetus would not be the one that's going back toward the heart, right? That's the umbilical vein, yes? It's the one that's going toward the placenta through the umbilicus or belly button. So it goes from the internal iliac artery, yeah, internal iliac artery, out through the umbilical artery, through the belly button, and then to the placenta. And then the umbilical vein comes back from the placenta through the belly button, right? Comes up the abdominopelvic cavity and dumps into the inferior vena cava. That makes sense?
Yes.
So fetal circulation is confusing to everyone, not just you. So make sure that you spend some time. With me, I have to list it out and then correlate the numbers with the picture, right? And actually the picture I think in your notes is slightly easier to look at than the one that's in the textbook, because it doesn't have a bunch of extraneous information on there. Okay, so we're going to do reproductive system today. And so we're going to start where we left off last time, and you guys are going to remind me of what you learned. First off, what is the default anatomic gender in humans? It's female. Okay, so remember that when we talked about becoming a male, in order to become internally, these are the internal reproductive structures. In order to become a typical male, what you're going to have to do is hit two switches, right? The first switch is Mullerian inhibiting hormone, which degenerates the female ducts, right? And then the second switch to go from here to here will be a burst of testosterone, right? In the female, this is the default that is going to occur. It actually requires estrogen at a certain point to support it, but estrogen naturally gets produced at a certain point by default. Okay, so as far as the external genitalia, which of these would be the external genitalia? The female would be the external genitalia. Okay, so what we determined last time is that anatomic maleness is really the presence of testosterone, right? And anatomic femaleness is not actually the presence of estrogen, it's the absence of testosterone. So, and then we talked about the disorders in which you can have the testosterone receptors not work and the anatomy develops more female than male. Now, the brain sex determination, so the brain sex determination is the thing that we know the least about. But the evidence does suggest that the brain sex determination happens at a different point than the anatomic genitalia determination. They think that it occurs later. They think it occurs 12 weeks-ish or so, and is probably because of another spike of testosterone. And so it seems as if the brain sex in humans is default female as well. And so you'd have to hit it with a spike of testosterone at the proper moment. So let's talk briefly about that whole idea of the variations of gender that exist. So male, female are what we're typically used to expecting, but there is also intersex. And what intersex is, it's not the same as trans versus cisgender. We'll talk about that in just a second. When someone is intersex, their anatomy is somewhere between male and female. For instance, you might have a very large clitoris, right? And the urethra might even move into the clitoris. So it's somewhere between a clitoris and a penis. But if the testes aren't here, it's not going to be a scrotum. So that person would be intersex. Does that make sense? So it's actually a physiological determinant, is intersex. So that's what intersex is. Anatomic ambiguity may occur. Any of the 5 determinants might not actually match the other. And then let's talk about cisgender versus transgender. I know you guys have all heard the word transgender before, but what does it actually mean with reference to anatomy and physiology? Well, there are at least 4 determinants of gender. The other ones I'm not really equipped to deal with, but these have to do with anatomy and physiology. There is chromosomal gender, yes. There is hormonal gender, estrogen, progesterone, testosterone, what quantities or proportions you have. There's anatomic gender, yes. And then there is gender identification, which is the psychological gender. If any of those does not agree with the other, the sort of determination would be that you are transgender. Does that make sense? So the rest of the people who have agreement, right? You're XX, you make estrogen when you expect to make estrogen and testosterone, or estrogen and progesterone, right? Your junk looks typically female, right? And you might even be reproductively capable, although you don't have to be, by the way, to be cisgender. And you identify as female. That would mean that you are cisgender. It's all in agreement. That makes sense? Okay, so that's what trans versus cisgender is. Okay, so it generally, this is cis versus transgender. And then with intersex, let's talk briefly about intersex. So can you see that when someone is intersex and they end up being not exactly internally or externally easily identifiable as an anatomic male or female, can you see why it's slightly more likely that they would be XY? Because in order to be male, you actually need to flip 2 switches, right? And it's really, really dependent on having the right levels of testosterone at the right time. So this person right here, if they had MIH but not testosterone, they would be something like this. Everybody started out with something that was kind of like a vagina, right? And so you would have something like that. Does that make sense? So it's more common for people who are intersex to be XY. But also, if you had just a spike of hormones for some reason during pregnancy, you could end up being intersex as well, right? If that woman who shot herself up with testosterone at exactly the wrong moment can end up with, for instance, a very large clitoris, which is something more like a penis, but she doesn't have testes in the scrotum, right? So those are how you can end up with intersex situations. Intersex situations from a parent's perspective are very difficult to figure out how to manage. Historically speaking, what they did is the easiest surgery they could imagine. So you have a kid who's got ambiguous genitalia, and you do the easiest surgery possible, and you just cut everything off, because it's way harder to make a functional penis than it is to just cut it off, right? So they did that historically speaking. But these kids, once they hit puberty, you could tell me 10 times to Sunday that I was a man, and there's no way that I would believe you. Right? And the same thing happened with these kids. You raise her and call her Susie, but she knows she is not a Susie. He knows he is not a Susie, right? There is no way, because gender identification had already gone on with the brain. A lot of suicides with these kids, of course. Now, what they really try to do, which is easier with educated parents than with parents who are not educated, is they do a chromosome test to see if you're XX or XY, but of course that doesn't mean your gender identification. And then they say you need to wait until the kid can gender identify, right? And those of us who have been parents know that it doesn't take until you're 14 or 15 to gender identify. They usually do it 2, 3 to 5 years old when they start to align with one gender or the other. It's not about sexuality. Gender is something totally different than sexuality, right? It's like, who am I, not who do I want to be with, right? That makes sense? So, and it's not just Barbies or trucks. It's like, which group of people do I gravitate toward, right? What kinds of things am I interested in? And when you get to be 5, I can ask you, are you a boy or a girl? And you will say, oh, okay, I'm a whatever. Does that make sense? Now, it doesn't always work that way, but of course it's very difficult to raise that child, right? What do you name them? What do you do? How do you answer questions? But it's difficult to raise children anyway, just so you know. There's a million ways you can make a mistake. Okay, so these are all sort of the clinical notes associated with gender determination. Now, what happens after that? Pretty much after that, your gonads don't do a darn thing until puberty. So you get it all in place, and then you have no appreciable amounts of estrogen or progesterone or testosterone until you hit puberty. So a kid is a kid is a kid for a while, right? Their gender was determined, but it's really not very active in the story until you hit puberty. And at puberty, what happens is your brain starts releasing a hormone called GnRH, which will ultimately communicate with your gonads and start making you make progesterone or estrogen. And then, of course, your secondary sex characteristics will become obvious, right? And you're going to start to get the male or female shape and all of that kind of stuff and become reproductively capable. So that's what happens. Now, this sexual orientation is a totally separate issue, but people always, in part because people don't talk about this stuff very much, but also in part because when we talk about LGBTQ, right? Lesbian, gay, bisexual, transgender, and queer. The T is all about trans versus cis. That's all about that. The LGB, that's all about sexual orientation. And they're really not the same question, although people do get discriminated against on the same spectrum. So what does sexual orientation have to do with this? Gender is who you identify as. Sexual orientation is who you are attracted to. And you can be cisgender and gay or straight or bi. And you can be transgender and gay or straight or bi. Does that make sense? And I know it's a very disturbing thing to think about, but I will tell you that the evidence exists that very few of us are completely homosexual or completely heterosexual. There is a spectrum. It's called the Kinsey scale. And most of us fall somewhere in the middle of the spectrum, especially in your teens and 20s. You tend to sort of find your space in the spectrum a little later. I'm not saying it's affecting your behavior. I am saying it's affecting what you are actually attracted to. So sexual orientation falls along a spectrum. There aren't very many people, I think it's less than 2% that fall exclusively heterosexual or exclusively homosexual. It's called the Kinsey scale if you ever want to look it up. But this, by the way, is psychology. It's not anatomy and physiology, although it will be, just so you know. We will eventually figure out the A and the P. And part of that will be brain scans of homosexual, heterosexual, transgender, all of that kind of stuff. We do know that there are some brain differences in homosexual versus heterosexual men for people who have donated their bodies to science afterward. But the pool is still so small, right? And then the other question is, what are you going to do with that information? So if you figure out that homosexual and heterosexual people have different brains, you can see how easily that could be abused, right? Right? So I want to know for science, but I certainly don't want anybody to abuse the information. Okay, so now let's go into female reproductive system anatomy. Female reproductive system anatomy. Okay, so the female reproductive system is something that a lot of people don't know a lot about. Take a guess, in my just limited pool of experience, which gender does worse on the female reproductive system on that test? Just take a guess. No, women do far worse than males on the female reproductive system. They can't find the parts, and they don't know the functions, and they don't know the names. I would like for you guys to break that trend. Women, will you please do better than the people who have not had one for their entire life? Okay, can you please do that? Part of the issue is that the female reproductive system has been cloaked in a whole bunch of shame. I've got some fascinating stories to tell you about that. And the other part is that most of it is internal, right? So like, how hard is it to find a penis? It ain't that hard. You're like, I wonder where the penis is. There it is. I wonder where the testicles are. Found them, right? So, but the female reproductive structures, a bunch of them are internal, right? And we weren't taught them very well. And you don't even have a really good angle on them yourself, do you? Right? You're like, oh, I know they're down there, but I'm going to have to actually have a mirror before I see things. And the other is the functionality is a little bit more complicated. Males produce gametes, right? They produce gametes, they produce sperm, and they also produce hormones. But females produce gametes, hormones. Their gametes are ova or oocytes. Estrogen and progesterone is the hormones for females. But they also have to be able to prepare for and support a developing embryo and baby, right? So you've got a complicated sort of anatomy and physiology going on there. So before we get into the specifics, I want to talk just briefly about that. Now, I'm not going to teach you too much about the menstrual cycle because it's phys and it's outrageously complicated, but I am going to tell you just a little bit about it so that you understand the big picture of what's going on. So the menstrual cycle, what it is, anatomically and physiologically, it's really the ovaries bossing the uterus around. So let me show you. Okay, so here's your ovaries, right? And the ovaries, in addition to producing an oocyte or an egg, are also going to produce estrogen and progesterone. And so progesterone primarily talks to the uterus, not exclusively, but primarily. So the ovaries get to boss the uterus around. What are they going to do? What they are going to do is, as the ovary starts to go through development of a single oocyte, and as it does this, it's going to get ready to ovulate. That's ovulation right there, okay? And as it does that, it's going to also be producing progesterone, and progesterone is progestation. That's how you can remember what it does. And what do you think progesterone should tell the uterus to do in preparation? What should it tell it to do? What should the uterus do in preparation for ovulation? What? Thicken the lining of the uterus, exactly. So progesterone will, as it increases, make you thicken the lining of the uterus in case of fertilization and implantation occurs. Yes, do you see that? So this is all because of rising progesterone levels, right? And then after ovulation, you don't get pregnant the day that you ovulate. You might even not have the fertilization the day that you ovulate. It takes between 4 and 7 days for the fertilization to implant in the uterus. So even if it got fertilized, it gets fertilized up here in the fallopian tubes. It takes a little while for it to get down. So what happens is, after ovulation, you have to keep the progesterone level high in preparation, just in case it's still going to occur. And then after you get out of the window in which an implantation and pregnancy could occur, then your ovaries go, maybe next month, and they drop the progesterone level and they start the whole process over again. Does that make sense? Okay, so this is the whole menstrual cycle. It's basically the ovaries pushing the uterus around. That's what it is. Everybody okay with that? Okay, so that's the menstrual cycle. It's way more complicated than that, and it's also involving estrogen, but that's a good intro to it. Okay, so now we are ready to do the female genitalia. Oh, by the way, this is ovulation. So it's kind of gross, but it's cool, huh? So this is an ovary, and in women who are trying to do in vitro fertilization, they will give you medication that causes hyperovulation, and then they go in there and harvest the eggs, right? So they actually happen to catch one mid-ovulation. Boop, boop, boop. There it goes. Okay, so that's ovulation. Okay, so female reproductive tract. Nobody brought their kids today, right? Okay, because you can teach your kids this stuff. It makes me feel uncomfortable for me to teach your kids this stuff. Okay. Huh?
Somebody ever done that?
Oh, yeah. They have brought kids to the reproductive tract. Okay, so here we go. Hi, guys. It's nice. Okay, so this is the female external genitalia. By the way, just so you know, this is not a vagina, okay? This is a vulva. The vagina is only part of the vulva. The female external genitalia collectively is called the vulva, or the other word for it is the pudendum. It's a word that I don't like because it means shameful. And it ain't shameful, it's how you got here. So that is the vulva. So let's look at the structures in the vulva. Some of them you definitely will have heard of before, and some of them you won't. Okay, so first this is the mons pubis. It's a fat pad that sits on top of your pubic symphysis, because humans are one of the few mammals that has sex face-to-face, and ow, 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 unless there's actually a fat pad there. Males have one too, but it's just not as thick in males. So that's called the mons pubis. And then you move down, and then you have, of course, the labia majora. Those are homologous to what male structure? Labia majora? Scrotum, exactly. And then the labia minora are homologous to what male structure? The skin forming the shaft of the penis, good. And then this area inside the labia minora is called the vestibule, which always cracks me up because it means waiting room, okay? Here's the waiting room. Here's the doorbell, guys, right there, just in case you wanted to know how to get in. That's it. Okay, so here's the vestibule, and here's the doorbell. That's the clitoris. The clitoris is actually not in the vestibule. It's above the vestibule. Okay, and in the vestibule, you have the external urethral orifice, or the urethral opening, and then you have the opening to the vagina, the vaginal orifice. And then you have something that most people have no idea exists down there, and that is that there is the opening right there to 2 glands called the greater vestibular glands. And when a woman is aroused, those glands will secrete a clear lubricating fluid that will lubricate the opening of the vagina. Okay? They are homologous to the bulbourethral glands in males, which, when a male is aroused, will secrete a clear fluid that cleanses the urethra and lubricates the tip of the penis. The take-home message there is that all things working perfectly, both the male and the female will have a lubricating fluid upon arousal, right? That's a good message to understand, is that there should be a lubricating fluid there. Okay, now, the other thing that is in there is really, well, actually two more. There's another set of glands that people are still arguing about. So I'll show you where it is from a different picture. Okay, so orient yourself to this midsagittal section. Here is the bladder and the urethra, right? Here's the vagina and the uterus, okay? So in between the posterior wall of the urethra and the anterior wall of the vagina, at least some women, but we do not know how many, have glandular tissue called the Skene's glands or the paraurethral glands. And those glands are homologous to the prostate in males. Now, if this were a male, wouldn't the prostate be right there? Yeah, it would be right there. So this is about the same space. So what do those glands have to do with anything? Those are called the paraurethral glands. And in some women, when a woman climaxes, these will actually produce a fluid called the legendary female ejaculation. The legendary female ejaculation. And when it occurs, the interesting thing is that this fluid will not leave the vagina. This fluid, like males, will actually be dumped into the distal end of the urethra, which can confuse the living hell out of people. They're like, oh my God, I thought I was having fun and then I peed the bed. Okay, so how do we know it's not urine? Well, interestingly, science. Two things. First off, females, like males, the internal urethral sphincter will slam shut when she becomes aroused, so it's very unlikely to get much urine in the urethra. And then second, all you have to do is test the fluid, right? And you look in the fluid and you find very little urea. You do find a little, of course, because it went through the urethra, right? But they do find a large quantity of PSA, which is prostate-specific antigen, which is telling you that it came from an area of glandular secretion close to the prostate. That makes sense? So that's a female ejaculation. And some women, at least, we don't know how many, have that gland. We still have a lot to learn about the female reproductive tract. The other thing is that erectile tissue. There is erectile tissue in the female, and you can see it right here. The first erectile tissue, so this is a female, and if I couldn't convince you that the clitoris is just a penis, this picture will do it. That is just a penis, right? That's the clitoris right there. It's just a little penis. But before we get to the clitoris, these structures right here, do you see those? These are called the bulbs of the vestibule. They are internal, okay? They're behind the skin. They're lateral to the labia minora, and these are erectile tissue. Okay, when a woman is aroused, these will become engorged with blood and become erect. Now, how does that make any evolutionary sense? If these become engorged and erect, what happens to the opening of the vagina? Yeah, it tightens, exactly, right? And why would tightening the vagina be good evolutionarily? Because it increases the likelihood of male ejaculation, which is pro-baby, right? And this is all just a baby-making trap. That's all it is, right? It's just trying to make you make a baby, okay? So these are the bulbs of the vestibules. These are erectile tissue. Now we're going to come back in just a second because this is also erectile tissue, as are these guys right here, okay? So the female has a bunch of erectile tissue just like males do. Now the bulbs of the vestibule are homologous to a structure you learned in lab, which is the corpora cavernosa in the male, right? Corpora cavernosa, where do those run? Where are the corpora cavernosa? They're, yeah, those two big erectile structures in the penis. These are the same homologous structure. Isn't that interesting? And they're actually in there. Okay, so those are the bulbs of the vestibule. We don't know if they're part of the clitoris, but what we figured out is that the clitoris probably isn't one structure. It's this big whole complex. I'll show it to you in just a second. Okay, so now let's look at the clitoris. So the clitoris is mostly internal, and to be more specific, we should say the female erectile structures. And so what you, of course, see if you know where to look, is that you'll only see the glands of the clitoris, which is just this little tip. But there's a whole freaking iceberg under there. So the glands of the clitoris is homologous to the glands of the penis. And then the tissue in the clitoris also has some homologous, oh, I said that one wrong. Sorry, the bulbs of the vestibule are homologous. These are homologous to the corpus spongiosum, and then the tissue in here is homologous to the corpora cavernosa. Okay, so these guys right here, I'll show you. So inside the clitoris, the structures, the behind the scenes structures were really only fully understood as of 2009, which is a long time, not very long ago. I mean, even for you guys who are young, it doesn't sound like very long ago. To me, it sounds like yesterday. It's mostly homologous to the male penis, but there's a little bit more of it. It develops from mostly the same embryological structure as the male penis, but what happens with the penis is that the urethra moves into it, and with the clitoris, the urethra stays separate, right? The urethra is separate from that. The glans has 8,000 sensory nerve endings in it. And when the woman is not aroused, of course, it is covered with the prepuce, which is a hood of skin that covers the clitoris. Good. And then, so what does the clitoris actually look like behind there? So it is this structure, but it's continuous with these. Okay, so one of the projects that my students did this semester is my 23-27 students, the lab aides, they have to do a project, and one of them decided to make a 3D model of the internal reproductive structures of the female, and they're printing them out, and there's going to be one on each campus, so I'll show you guys what it looks like so that you can get a good appreciation. So this is what they made for me. Okay, oops, let's get you right. So can you orient yourself first? Yeah, you see where we are? Okay, so now what do the internal reproductive structures look like? Okay, so first let's find ourselves. This is the vagina, right? This is the uterus, these are the ovaries. The structures that we are talking about that are part of the erectile structures are these. These are the bulbs of the vestibule that we already talked about, and then this is all clitoris. The clitoris is not just that little button at the top, it's all of those structures. So if you look at that, you can imagine how the clitoris can actually become erect. It's actually the same structure in a male. The male penis has erectile structures, but the erectile structures don't just stick out, they actually go behind the body wall. So it's like blowing up a pool float, right? You start blowing it up and you smash it against something and then it stands up. Same thing with the clitoris. You blow up the pool float and the clitoris actually stands up. That makes sense? So this is the erectile structures internally. Fascinatingly, most of these structures have been understood to one degree or another since the 1500s. But there is some gender discrimination and some religion and some sexual and some basically sexual fear tactics that went into it. So up until the 1950s and 60s, when you saw this picture in even a medical school textbook, the clitoris wasn't even there, even though we knew it existed. People were so very uncomfortable with talking about any female reproductive structure that didn't have to do with baby making directly, that they just basically made a nothing right there. There was a nothing right there. So doctors who are treating you now learned from medical school books without that picture in there, without the clitoris picture in there. Now, I'm not saying they haven't continued their education. In all likelihood, of course they have. So they just took it out because it made people really uncomfortable. It was a female OBGYN nurse who in the 1970s said, "This is not what it looks like, okay? This is not what it is." And she campaigned to get the anatomy understood. She did tons of cadaver dissections. She figured out the internal and the external anatomy, and people wanted to lynch her because of it. They told her that she was not Christian. They told her that she was being disrespectful to male and female roles. She almost got run out of her profession just for teaching the correct anatomy. So there is a tremendous lag time between when this stuff goes in here. As a matter of fact, even in your textbook, you will see that there is a complete description of the male sexual cycle, and there is 0 in there of the female sexual cycle. So we are still being the feminists who battle for this kind of stuff to make sure that it's actually well understood. So the clitoris is actually pretty well represented in your textbook. So the parts that you see this is the glands in the body of the clitoris, and these are called the crura or crus, and those are behind. So can you see, because they're wedged behind the bone, that as soon as they start becoming engorged with blood, it'll make the entire thing stand up? You see that? Okay, so that's the clitoris. All right, so now let's move on to the ovaries. Okay, so the ovaries, okay, so here's an ovary from a midsagittal section, and here is an ovary here, right? And so they're weird looking. They're way smaller than I expected them to be. When I started dissecting things, I was like, really? That causes all those damn problems? So they're kind of little, and they have the texture of like large curd cottage cheese because they're always kind of lumpy on the surface. It's kind of weird. Did you guys get to see them? We don't have very many females with ovaries. We've only got one on the Redwood campus. We don't have two because the females that we get are so old, and they used to do radical hysterectomies far more often than they do now. So we don't often have a uterus and ovaries, but we do have one. Okay, so the functions of the ovaries, they produce gametes, which are oocytes or eggs in females, and they produce estrogen and progesterone. They are homologous to what structure in the males? Testes, exactly. Here's something funny. The ovaries actually are not in contact with the fallopian tube. So imagine, here's my fallopian tube, right? Okay, and this is my uterus, and here's my ovary. They actually they're not attached to one another. Now, under high levels of estrogen, what will happen is the fingers of the ovary will fold and hold, but it's still porous and you can still get stuff out there, okay? So it's not actually attached. So like we talked about at the beginning of the semester, when you ovulate, you actually don't ovulate into the fallopian tube. You ovulate and you hope you'll get into the fallopian tube, because what happens is the fallopian tube has smooth muscle lining it, and it waves a peristaltic contraction, and then it's got ciliated simple columnar epithelium lining it that waves that way. They call that the courting of the oocyte. But it doesn't always work, which means that you can ovulate into your peritoneal cavity. And since the whole damn thing is open, that means the sperm can get out into your peritoneal cavity as well. If it makes it all the way up here, all the way up here, all the way up here, and out, that means that you can have a fertilization in your peritoneal cavity and an implantation in your peritoneal cavity. So all well and good if you implant in the uterus, but what if you implant on the colon? That's called an ectopic pregnancy, cannot be carried to term, will freaking kill the mom if it stays in there too long. So the only ectopic pregnancies that I've ever read about that have been carried to term were there's two journal articles that I found about ectopic pregnancies that actually implanted not inside the uterus, but on the outside of the uterus, but it had access to the same blood flow. And I can't say it was carried to term, I can say it was a live birth. They actually let the pregnancy grow up until the first part of the third trimester, and then they delivered the baby. Of course, it can't be delivered vaginally, right? And it wasn't even really a cesarean section, it was really just a abdominal surgery to get it out of there. Isn't that interesting? But all of the rest of the ectopic pregnancies are very, very dangerous for the woman, and it can't be carried to term. Okay, so the blood supply to the ovaries is primarily through the ovarian artery, which is the gonadal in a female. And then there's also a branch of the internal iliac called the uterine, and the uterine gives blood supply to the uterus, but it also has a branch that goes up to the ovary as well. So it got blood supply from two locations. Nerve supply is autonomic nervous system. And let's look at the ligaments, and then we'll go back to the function for a second. Okay, so what is holding the uterus up there? A couple of different things. First off, this is called the suspensory ligament, and it holds the, sorry, I said uterus, I meant ovary. It holds the ovary to the body wall, so it's like suspending it from the body wall. Then there's this guy right here called the ovarian ligament that goes ovary to uterus. This is not a tube, it's just a ligament holding them together, okay? And then there's this big broad ligament that's kind of behind and holding on to the uterus and the ovary. Okay, and while we're at it, there's another ligament down here that's primarily the end of the uterus and the vagina, and that's called the cardinal ligament or transverse cervical ligament. So that's basically how the ovaries are sitting there. Okay, so now let's look at ovarian function, which is kind of interesting, structure and function. Okay, first, the outer layer of the ovary right here is called the germinal epithelium, and the germinal epithelium is continuous with the visceral peritoneum. This is where ovarian cancer occurs. And I told you guys before that it's very likely to be misdiagnosed because it just causes this sort of random irritation of the abdominopelvic cavity because it's all one continuous sheet. That makes sense? Okay, but then the other interesting parts are, of course, this is the ovarian cortex. That's where all the action occurs. This is the ovarian medulla. Okay, this is the hilus or hilum, where the tubes come and go. Okay, the medulla is blood vessels and nerves. So let's talk about what happens over a cycle. Here's what happens. In a regular 28-day cycle, what's going to happen is a woman will start one of these structures right here called a primordial follicle. Those have cells in them that have 46 chromosomes, okay? And then once per cycle, one of these is going to start to go through maturation. And as it goes through maturation, of course, it's going to divide its chromosome number in half by meiosis, right? Because how many chromosomes should an egg have? 23, and a sperm? 23, otherwise you are not going to produce something that's a completely normal human, right? So you're going to go through meiosis when you're going through this process right here, and then ovulation, right? And then of course that hopefully will get picked up, right? And if fertilization occurs, it generally occurs right out here in the fallopian tube. And then what's going to happen is this structure is called a follicle that was developing the supporting egg. It's going to stay around for a little while and continue to pump out progesterone, just in case a fertilization occurs. And then after you get out of the window, when fertilization can't occur, it's going to go, let's try again next time, and it's going to start the whole process over again with a different one. Does that make sense? So these guys right here are called primordial follicles, and they are 46 chromosomes. You are born as a woman with about 1.5 to 2 million of those. That is more babies than anybody even intends to have in Utah, right? 1.5 to 2 million primordial follicles. In a regular reproductive lifespan, you will ovulate about 400 of those. Okay, the rest are just degenerated as follicular atresia. But let's talk about this sort of truth, sort of myth that everybody has. People say you're born with all the eggs you're ever going to have. That's not true. You're born with all of these that you're ever going to have. And then they age with you, okay? And meiosis is a really exact process, right? You have to do meiosis 1 and meiosis 2, and everything has to work just fine in order for you to have a normal egg or sperm. What happens as you age is that these are less likely to go through meiosis correctly, and the likelihood of chromosome abnormalities like Down syndrome and things that are far more severe than Down syndrome like trisomy 18 and 15, those things that will actually be spontaneously miscarried or cause major, major problems, that increases as the woman ages because these age with you. What's the difference between that and males? In males, you have similar structures, of course, not in the ovary, but those will go through mitosis all the time, making fresh ones, and then go through meiosis to make sperm. In females, they don't do that. They don't go through mitosis all the time. That makes sense? So those age with you. So I can't remember the last time I looked at the statistics, but if you're in your 20s, I think the likelihood of having a chromosome abnormality pregnancy is something like 1 in like 2,500. But by the time you're in your 40s, I think it was at 47, the likelihood is 1 in 16. So it gets dramatically more likely. Does that make sense? Okay, so got all that. Okay, so we already did the supports, and we did ovarian cancer. Okay, so fallopian tubes is next. Also called uterine tubes, or what else do I call them? Oviducts. Oviducts is actually the preferred term, but I can't get used to using it. So when you're looking at these guys right here, basically what we have is we have an infundibulum right here, and then the curve. That's the usual site of fertilization, and that's called the ampulla. Okay, so did all of you guys know that fertilization generally does not occur in the uterus? It occurs out here. So fertilization generally occurs here, and then what would happen is, of course, the egg, if it was fertilized, would start going through cell division, 1 to 2, 2 to 4, 4 to 8, 8 to 16. And that is occurring as it's going through the fallopian tube. So infundibulum, then ampulla, then isthmus, which is this narrow part, and then the narrowest part right here is called the uterine part. Okay? Now, what would happen if a fertilization occurred and the woman had scarring of the fallopian tube? Then can you see how that could cause infertility? right? You can't get, because it gets bigger, 1 to 2, 2 to 4, 4 to 8, 8 to 16, 16 to 32. So this is relatively narrow to begin with, and if the woman has scarring of the tube, a lot of times you can't get it all the way through. And that can cause either infertility, obviously, or a tubal pregnancy. And a tubal pregnancy is a type of ectopic pregnancy. Ectopic just means out of place, right? But it's a specific type in which if you can't get through here, you will actually implant in the tube, which cannot be carried to term and can and will kill the mom if it continues to grow. That make sense? Okay. So how do you get that scarring of the tube that can lead to infertility? Pelvic inflammatory disease is just sort of a general irritation that can be because of STDs, and it increases in likelihood because of STDs, but it doesn't have to be. If a woman gets a bacteria from her urinary system into her vagina, then it can cause, for instance, if you had a UTI and it made it into your vagina and happened to survive there, it usually won't. It depends on what kind of bacteria it is. Then it can cause irritation and scarring here. Or if your girls are not taught to wipe properly. You wipe front to back, ladies. You do not wipe back to front, right? You don't want to get all that stuff that's supposed to stay back there. So that's another frequent source of pelvic inflammatory disease and female infertility. And most of the time, the women will not know that they have this until they actually try to get pregnant. They won't know that they had any kind of infertility issues. Okay. So we already talked about the cording of the oocyte, pelvic inflammatory disease, and ectopic or tubal pregnancies. Okay, so next is the uterus. Oh, by the way, the tissue, ciliated simple columnar epithelium, right? And smooth muscle in the wall as well. Now, here's the uterus. The uterus is also called the womb. This is, of course, the site that will house the baby. Here's the parts. Fundus, looks like a little trampoline, fun to jump on, right? The body. Okay, the isthmus is where it gets narrow, and this part where it projects into the vagina is called the cervix. Anybody know what the function of the cervix is? Yeah, exactly. It holds tight whenever your progesterone levels are high, right? It's the baby keeper in her, okay? And when a woman is about to give birth, they're looking for dilation. I was so confused for a ridiculous number of years. I was always like, oh, the vagina dilates to make room for the big old freaking watermelon to get out of there. But no, it's the cervix. So, of course, the vagina is like stretchy enough that it can have a baby come through it pretty much at any time. But the cervix is tight, and you have to wait for it to open up, right, in order to get that freaking little cantaloupe head out of there. Okay, so and we'll come back to cervical cancer in just a second. So one of the things that people actually do relatively poorly, and I want you to do well, is to make sure that you can identify things in a midsagittal section. The first thing that so many people don't know is that women have 3 holes, and you need to know what they are, anterior to posterior. The first one is here. What's that? The opening of the urethra. The second one is here. That is the vagina. And the third one is there. That's the anus, okay? And you should be able to do it from here as well and also find the clitoris with reference to all of those things. The other thing is that people can't tell the urinary bladder from the uterus. But you can, right? Okay, here's the urinary bladder and here's the uterus, okay? Make sure that if you can't find them, you follow the tube up until you get to something that looks reasonable. I am not kidding. People get these wrong all the time. People freaking flat flunk the female reproductive system part of the test 4. And I think my suspicion, and I don't know, maybe you can tell me I'm wrong, my suspicion is that people somehow conflate ignorance with morality. Like if I don't know what any of it is, obviously I'm an incredibly moral person. No, you're just not as smart as other people, right? Okay, obviously you don't have to know what they're called in order to use them because we have 7 billion people on the damn planet, right? So people don't know. Okay, so you got to find all of those structures. Oh, do you want to know a story? I'm going to tell you a story. You ready? No, I'll tell you that one next time. Okay, I'll tell you now. Okay, so it is tragic for people to not know the anatomy, and it happens very, very frequently, and it happens frequently in this state too, because there's I don't know, maybe you guys could tell me at some point what your education about the reproductive system was like in public schools. I would love to know, because my son's about to get there. And trust me, he knows more than you guys do already, but I would love to know what you learned. I know what you're limited from learning. I'll show you guys. What?
Yes, a lot. We're taught nothing.
You're taught not, you were taught a lot?
No, not a lot. Like,
No, they're not allowed to. Do you know that they're actually not allowed in public school to mention the words condom or homosexuality, or they're not even supposed to show any structures that are not involved in reproduction?
this is stupid.
I know, I'm like, you just want dumb people. You want a bunch of dumb people who are going to get knocked up on accident because they don't know where the parts are. And abstinence-only sex education states have they have the highest rates of teen pregnancy.
Because they don't know.
Yeah, because they don't know. So let me tell you an ignorant story that you would never make. I know this is not you. But first off, we'll talk about the hymen next time, but let me show you that women have a partial or complete covering of the vagina. These are hymens. I don't know why this isn't in your textbook. This isn't even controversial. So what would happen if you were a woman who had this imperforate hymen? An imperforate hymen actually has microperforations, so the woman would menstruate, but it would take like 3 weeks for her to menstruate every time. So this woman, in combination with not having any education about her anatomy, then gets with a man who also doesn't have any education about his anatomy, right? And then the imperforate hymen is sometimes so thick that it actually has to be surgically opened before the woman can have vaginal sex, okay? So get these two together, and then you try to have sex, and neither one of them knows anything. And then you get tragic situations in which you try and try to have sex, and it won't work, and it will not go in the vagina, and he doesn't know what the vagina is, and she doesn't know what the vagina is, and they end up having sex through the urethra. And yes, this is a journal article. I did not make this up. I actually went and made sure that there was evidence. They end up having sex through the urethra, which is not stretchy, okay? And they only came to the doctor because she was getting recurring urinary tract infections. She was having urinary incontinence, and she was super worried because she couldn't get pregnant. So that's the kind of thing that abstinence-only education gets you. That's the kind of thing that it gets you. So nobody is better off being dumb. Just so you know, it is not better. Okay? So, there are several different types of hymens. We'll talk about hymens next time as well. Okay, so I thought that story was worth telling you, right? Somebody told me last time that they didn't believe me, and I was like, I can find the journal article, and I actually found it. And yeah, it was a pretty tragic situation. But she didn't know what it was supposed to feel like. She just thought sex was supposed to be brutally uncomfortable and horrible, right? Because if you, what? It wasn't here in Utah, although there is another story that's here in Utah, which is an anecdotal story about two people trying to get pregnant, and they were trying to get pregnant by